Time is 12:33, and I'd like to call the September 2017 meeting of the Board of Health of the Spokane Regional Health District to order. At this time, we do have a quorum. No, I thought 5. 6. We still don't have a quorum, and I can't add, as was made apparent to me last night by my daughter. Let's begin with a roll call of those we have at this time, starting with Mr. Kearns.
Josh Kearns, Spokane County.
Bob Lutz, Health Officer.
Tony Smith, Administrator.
Chuck Hafner, appointed citizen.
Kevin Freeman, City Millwood.
Susan Boyson, appointed member.
Brian Beggs, City of Spokane.
Michelle Fossum, Legal Counsel.
And Pitt Smokel, Recording Secretary.
Thank you. So at this time, we have our list of citizen input, which is going to be long today.
Someone just came in to if they haven't signed
up. So we are at 17 folks today. I will do my best pronouncing names. So please, some of you are regular attenders, some of you are new. Let's see. So I remind folks that they have 3 minutes to speak. Given the number of folks today that we have, that will be timed, and I would ask that we rigorously enforce that time limit. So I will be today interrupting folks at the end of 3 minutes to give everybody a chance to speak and to complete our regular business. We ask that you state your name and address for the record and for our recordings. And so we will begin to go through these people in order. So I would ask folks to be prepared. Our first up is Barb Howard.
Hi, my name is Barb Howard. I live Spokane Valley, and I'm here as a cancer survivor. And I really like my picture and everything else, but I already lost my breast. I don't want to lose anything else. My immune system is shot. I'm not trying to take anybody's kids away from them, any rights away from them, but I catch anything that's out there. So please, keep it the way it is. Have the kids, if they don't want to vaccinate them, then keep them home. But please, think of the cancer people. Go to cancer care. Go to chemo. I had my head in a bucket going through that. No more. Thank you.
Thank you very much. Next is Carol Allen.
My name is Carol Allen. I live at 14722 East 24th Avenue, Spokane Valley. I have lived in the valley for 40 years. I'm a retired professor of community public health nursing from WSU. The resolution on parental rights proposed by the current City Council includes many items that are the purview of the state and are contrary to state law. I oppose it. As a parent, I understand a parent's concerns that their children be protected from illness. Immunization and the right of teens to seek health care without parental interference are measures to protect the child and the community of other children and adults with whom they interact. I have administered vaccines for more than 50 years. I have studied the science. I have read the peer-reviewed research. Yes, vaccines have side effects. So do Coca-Cola, carrots, and candy, but children get them. The incidence of serious adverse reactions to vaccines is very low. The diseases they protect us and our children from have much more serious consequences. Most of you have never seen a child with polio in an iron lung, or a case of measles encephalopathy, or an adult with chicken pox near death in an ICU. I have. I never want to see it again. I want my community protected. Some children and adults have compromised immune systems, people with cancer, people with various illnesses of the immune system. They cannot be immunized. It is our duty to protect these adults and children by immunizing everyone who can be immunized. Teens also need to be able to seek health care when needed, especially when they think they may have a sexually transmitted disease. Teens are unlikely to report their suspicions to their parents, especially parents whose belief systems prohibit sex before marriage and who want to leave their children ignorant of sexuality until they are adults. We have an epidemic of gonorrhea and chlamydia in this area, and syphilis is rising. When teens can seek treatment, we can intervene to protect the community. Thank you very much.
Thank you. Next we have Kim Helm.
Hello. Today I'll be talking about the aluminum adjuvant used in vaccines. It's a xenobiotic, which is a foreign substance not made by the body that has immunostimulating and neurotoxic properties. Just a few days ago, on September 18th, this online study was released and will be published in the December 2017 issue of the Journal of Inorganic Chemistry. Dr. Christopher Shaw and his colleagues at the University of British Columbia have established convincing biological evidence linking aluminum used in vaccines to autism. This paper reports measurements of cytokines in the brain of animals injected with aluminum adjuvant. Cytokines are chemical signals that instruct a response from the immune system. The same cytokines are elevated in human autism. This upregulation of cytokines produces a massive increase in inflammation. Most vaccines contain aluminum. Aluminum is a proven neurotoxin in amounts received from vaccines. Vaccines in combination can result in toxic aluminum overload staying in the body, oftentimes for up to 40 years or more. Even the aluminum in a single vaccine can be harmful because the aluminum in that form is more dangerous than ingested aluminum. Specifically, vaccine aluminum is harder for the body to eliminate because it is transported around the body differently than ingested aluminum. It's natural and normal to ingest small amounts of aluminum in food and water. Ingested aluminum is an ionic form which is readily removed by the kidneys. Also, ionic aluminum is blocked from entering the brain by the blood-brain barrier. The low absorption, rapid elimination by the kidneys, and barrier to the brain entry adequately protects the brain from aluminum. However, nanoparticulate aluminum from vaccines cannot be removed by the kidneys. The particles are far too large to be filtered out by the kidneys. Long before they can dissolve completely, immune system cells swallow them up and spread aluminum as they travel through the body. This is dangerous because the aluminum-loaded cells carry aluminum nanoparticles to tissues, including the brain, which are damaged by very small amounts of aluminum. In a nutshell, the study found that when smaller doses of aluminum adjuvant were consistently injected over a short period of time, like during childhood vaccines, the aluminum was more likely to end up in the brain. In the context of massive development of vaccine-based strategies worldwide, the present study may suggest that aluminum of adjuvant toxokinetics and safety require re-evaluation. This convincing biological evidence linking aluminum adjuvant to autism should cause concern for all parents and healthcare professionals. Every minute, a new child is diagnosed with autism, and every minute it strikes me that autism may be completely avoidable. Have we lost sight of what we're debating about here? Are you arguing to be right, or are you arguing because you believe? And if you believe that vaccines work and protect you, and you have come to this conclusion based on non-biased research, good for you. I encourage you to continue your research, and if you choose to vaccinate, then you should be able to go forward.
Thank you very much.
Be protected,
thank you.
And that I will not harm you.
Thank you. So next up is Amy Fleck.
Exclusions are severely damaging and dangerous to students. The American Academy of Pediatric policy states that out-of-school suspension and expulsions should be avoided as much as possible, and that suspended and expelled students are up to 10 times more likely to drop out of school. It is an objective fact that some children will respond to suspension or expulsion with self-harm attempts. If you Google suspension, expulsion, suicide, it will return pages of reports, studies, and stories about the potentially fatal risk. It is easy to understand why you are tearing students away from their friends, activities impacting their grades, scholarships, graduation, and college qualifications. If you are going to kick kids out of school, it better be for a darn good reason. Youth suicide is the second leading cause for death for Washington youth aged 10 to 24, about 100 per year. Compare that to mumps in the 60 years, from 1920 until school rules were phased in 1980, there were only 50 mumps mortalities. That's total over 60 years. The knowledge of the damage and danger of suspension and expulsion has caused a radical reform of disciplinary action in the schools and any group that deals with youth. There are pages and pages of policy that strictly governs who, why, how, and what happens to a student who is taken out of school. Normally, when an administrator kicks a kid out of school, they know who the student is, their emotional and mental health status, and those factors play a part in the decision. There is no context in school discipline in which a large group of students, where the administration has no handle of who these students are as individuals and what the possible effect exclusion will have on them, would be kicked out for 25 days at a time. Disciplinary suspension and expulsion policy has significant requirements for anything beyond 10 days. How many pages of policy govern vaccine exemption exclusion? 0. It is entirely unaddressed. That means there is no governance, no criteria for what constitutes a safe, necessary, proper, and effective exclusion. This current lack of policy means that now an exclusion is simply to stay off of campus. If you are lucky, you get homework packets and you are on your own. There is no screening of students prior to, during, or after exclusion to determine they may be at risk. We know that a student had been excluded, passed away by suicide some weeks afterwards. If that exclusion had been a disciplinary suspension, that student's passing would have been prompted an investigation to ensue. That policy and procedure was followed to letter by all involved. In our opinion, exclusion, as it is currently being imposed, constitutes a reckless endangerment of student well-being. Spokane and Washington State need to do it better than this by these students.
Thank you.
So, was that mandatory or voluntary when our children were excluded?
Thank you. Thank you. Next we have Jaqueline Gallo.
Jaqueline Gallo, City of Spokane Valley. Hello, this is my 7th meeting since February, and believe it or not, I'm going to tell you how it could have all been avoided. To recap, you have heard dozens of parents and students give testimony about the disruption and damage they experienced during the Spokane Regional Health mumps exclusion policy. You learned that the exclusion had no chance of slowing or interrupting the outbreak, and you saw that for yourself. And you tried to intervene for parents and students, and I want to thank you for that. After school ended and parents assessed the situation, they were angry that their children had been forced out, some for more than 3 months, for no good reason. And this anger was heightened as they learned that it is an objective fact that school suspensions and expulsions can directly provoke self-harm attempts in youth. This is something public health and public schools know or should know, but did they warn us? Did our exclusion notice include that information, along with a list of certain behaviors for us to watch out for, be vigilant, and to immediately seek intervention if we observed them in our children? No. And when an action subjects students to a real risk like this, isn't there a responsibility to warn parents? At this point, we went to an attorney and said, we have been mistreated. And the attorney agreed and told us, you have been mistreated, let's look at this. The next meeting, he then reported, this is not as straightforward as I thought. It turns out the exclusion was not mandatory, and your kids were free to attend school. We were shocked and thought that he must have made a mistake. So at the July meeting, I directly asked your lawyer, were the exclusions mandatory? Expecting a simple yes, of course they were. Instead, she refused to answer and told me that she is the board's attorney and not the public's attorney. Confused, I then asked Director Smith, were the exclusions mandatory? Again, expecting a simple yes, of course they were. Instead, I get a deer in the headlights look, and when he composed himself, Smith doesn't answer and say, yes, of course they were, but instead asked me, did you check the box? And I asked again, and Mr. Smith, I'm pretty sure we discussed this. I asked again, and Mrs. Smith says, I'm pretty sure we discussed this in the meeting. Considered how ridiculous that answer is, what we have been doing for the last 9 months was common knowledge the exclusions weren't mandatory. I answered, no, it wasn't. And Smith said, well, maybe it was a manager meeting. My next thought was, is the board part of this charade to misrepresent the exclusions were mandatory? If you are, then shame on you. But if you aren't, then welcome to our world where government functionaries feel it is acceptable to behave in this manner towards us because of our health choices. But in retrospect, this explains a lot of what we have seen in this meeting. Recall how no one seemed to have a clear answer about who decides to exclude? Consider all the efforts and gymnastics the Spokane Regional Health staff went through to keep this disclosed. This entire situation...
Thank you very much.
Right, thank you.
Next we have, and please, I might get this wrong, Josh Carnot. You got it. Thank you. I remind folks, please name and address, or at least city location for the record. Thank you.
Josh Carnot, 4108 South Conifer Court, Spokane Valley. This entire situation could have all been avoided if the SRHD was honest back in January. A parent came in and warned you that the schools were not prepared and did not have the capacity to support students. One of the board members directly asked the staff, do you know if the students are receiving services? And the SRHD staff answered, we don't know, we can't answer that, indicating they kicked this whole thing off without even finding out if the schools were capable of teaching the kids on exclusion. Wouldn't that have been a good time to disclose? Well, it is a voluntary mandatory exclusion, so if you insist your kids may continue in school, but it is against our advice. Then in the February meeting, when you learned that it was only vaccinated students becoming infected and wanted to know if you could overturn the mandatory exclusion and make it voluntary, wouldn't that have been another good time for staff to reveal it was actually mandatory? Board members directly asked staff, can we make this voluntary? Do we have the authority to overturn the health officer? And somehow Director Smith and your lawyer didn't think this would be a good time to say anything. If the exclusions weren't mandatory, why go through the pretense of a special meeting to discuss if it could be overturned? This explains how the special meeting turned into the dog and pony show it did, where the key subjects was the exclusion medically necessary, and could it be rescinded, were never addressed. How could your attorney's report at the special meeting about your legal scope leave out the fact that exclusions weren't mandatory? SRHD policy representing that exclusions were mandatory resulted in hundreds of Spokane students having their educations disrupted, GPAs, scholarships, graduations, and college acceptance threatened. They were subjected to very real damage and risks. I want to offer some constructive suggestions. If you are going to represent an exclusion as mandatory, it should be mandatory. If you are going to impose an exclusion which you know has the very real potential to cause mental, emotional, and physiological harm to students, you have a responsibility to inform the parents, give them guidance on what to watch for, and an action plan if they observe warning behaviors. If you are claiming that the exclusion is required to keep susceptible students off campus, don't let the recently vaccinated back in the same day. If everyone knows that if the vaccine is going to stimulate antibodies, it will take weeks. If you have a poor performing vaccine where the number of vaccine failure students is several times greater than the number of exempt students, don't pretend removing this exempt subgroup will slow or stop overall transmission. When you know that infection is centered in a specific indefinable group, as you did in this outbreak, take interventions there. There are schools which would have had no cases if that group had been excluded instead of the exempt students. Stop mistreating the exempt student. Stop misrepresenting that the exempt student had anything to do with it. Use transparent reporting that clearly shows vaccination status by age, so we don't have to be detectives. If you insist on the vaccination status unknown category, which is not when a patient doesn't know if they were vaccinated, but only when you confirm it, add in the column for self-reported vaccinated.
I'm sorry, your time is up.
Thank you.
Thank you. Next, we have Brooke Green.
My name is Brooke Green, and I'm from Spokane. So continuing on what he was saying, so why would anyone misrepresent their vaccination status? How many adults have the records? How many have childhood pediatricians still in practice? If you're going to include statewide numbers, say so. You should coordinate with the schools to be certain they're able to support students off campus for months at a time before you kick them out. This entire practice requires a set of governing policies. I don't think that any of these suggestions are outrageous, but merely reflect the way that most people think businesses should be conducted. To close, I'm going to assume the board was not involved until I learn otherwise. I want to think that elected officials conduct themselves in a more ethical fashion. If I were a board member, then I would be very disappointed to have been misled by the agency over which I'm responsible. I would want to have an investigation into any potential ethical, professional, administrative, or even legal violations posed by the withholding of this information and the active misrepresentation about the status of the exclusions. This certainly appears to be an intentional, coordinated effort among SRHD staff to manage the information presented to the board to influence their decision-making. Is this appropriate? Thank you.
Thank you very much. So next we have Nancy Babcock.
Unvaccinated exempt students played no part in the Spokane mumps outbreak. The health department has been very unreliable with the outbreak demographics and has at times mixed in state numbers with the county numbers, making it impossible to determine what really happened in Spokane. Representatives of the Spokane County Health Board kept saying the unvaccinated students were being excluded from school to protect them from catching mumps. Number one, it's the parents' job to make these decisions for their own children, not any government body. And if parents want their children to have natural immunity rather than man-made immunity that carries a risk, it should be the parents' right to do so. Number two, if the health board's true agenda was protecting children from mumps or any other childhood illness and not punishing unvaccinated students, then why is it acceptable to have a previously unvaccinated student run out and get a vaccine and return to school the same day, when all scientific literature acknowledges vaccines don't build antibodies that quickly? If the goal is to protect the child, then shouldn't these kids also be excluded from school until their antibodies are raised enough to protect them from the illness? Why are they allowed in school the same day? It's complete hypocrisy to say you're trying to protect children when your actions do nothing to protect them whatsoever. You can say it's not a punishment to exclude them from the school, but the actions of the board prove otherwise. Exclusion was prompted when 2 vaccinated kids got the mumps and the exempt kids were sent home for 25 days. 25 days is 2 infection cycles. In several schools, vaccinated students kept becoming ill long after there were any unvaccinated students and exempt students in school. Exempt students were nowhere in the infection chain. If you look further, it appears that there was no or very little at-school transmission. Students were not going to school and catching mumps. They were catching mumps and going to school. The fact is, mumps never works in 12% of recipients, which is 3 times the number than the 4% who are exempt. Even worse is that the vaccine doesn't seem to work at all in certain ethnic population. Spokane has a large community of this ethnic group, as does every other county in Washington with a mumps outbreak. Mumps is being transmitted off campus, in their homes, and in social events. Mumps is not airborne transmissible. You must ingest the through nasal or saliva droplets of an infected person, usually by sharing, eating, drinking utensils, food, or close physical contact. The exclusion is an example of a government agency enforcing policy long past the point of being rational to the point of being absurd, and Spokane students paid the price. Thank you.
Thank you very much. Next we have John Ott. I do remind folks, please name and location for the record. Thank you.
Hello, I'm John Ott, Spokane County, 16434 North Morton Drive. I would just like to say I just got back from Maui, was over there for 3 weeks, and they're in the middle of a mumps outbreak. Found that kind of humorous, talked to some parents over there, and everyone, there's only 3 of them, but all their kids had been vaccinated, and they were up to date and they come down with the mumps. It's the same ethnic community that we're dealing with here. I'd also like to then switch a little bit and talk about talking to the health board about starting a task force to look into what's causing autism. That seems to be what everyone is worried about, and the numbers continue to grow. So why don't we start our own task force and start gathering our own data? No different than if we had an E. coli outbreak. We would start figuring out where these people are eating, what's causing them, what's caused it to come down, before we could find the center of what's causing it. So my suggestion is to get proactive. If it's not the vaccines, what's causing it? Is it carrots? Is it Coca-Cola? If it is, we need to get those off the shelves. But I would suggest, instead of us going back and forth, find the funds to gather our own research, because the numbers we're hearing now is 1 out of 28 kids are coming down with autism. So I would suggest the board find a grant and gather up their own data here in Eastern Washington and see if we can't make a progression of what we think or what's leading to this outbreak of autism. Thank you.
Thank you very much. For a general announcement at this time, citizen input ended at the beginning of the meeting. The meeting had begun. We are accepting no further citizen input at this time. That's the decision of myself as the chair of the board. So next we have Petra, I want to say Hoy.
We thought we'd all come up together to see. We just walk.
And who is coming up?
They're the people next in line. Is that
okay?
Okay. Yeah, I'm from Spokane Valley. Thank you for meeting us today. Vaccination should not be a controversy in our country. I'm a pro-science gal and had hoped we could be working on other public health issues like mental health, depression, bullying, and whatever this vaping thing is. However, here we are. I have 2 children who attend CV High School. Let me tell you a quick story about their friend Jane, who we met in elementary school. Jane was an orphan in China. She survived long enough to have open heart surgery in China, where they actually removed the membrane around her heart. Jane was adopted by my friend Becky and had another open heart surgery at UCLA, then another at UW. While at UW, they were struggling with mold, which ended up inside of Jane, attacking her little body. Thankfully, Jane survived again. Do you remember the swine flu outbreak about 8 years ago? Well, Jane's mom was really worried about that. If Jane got the swine flu, she would have a hard time surviving, even though she is vaccinated. So we scrubbed the second grade classrooms. We disinfected and cleaned to try to keep Jane safe. The PTO president walked by one day and asked what we were doing. We told her, and her response was, "I'm glad you let me know about the swine flu. The school is supposed to tell me about these things since my kids aren't vaccinated." When I pressed her, she said she doesn't believe in vaccinations. I wish I would have said that these vaccinations that she doesn't believe in could save Jane's life. Maybe it would have been a teachable moment about herd immunity and us all doing our part to protect the vulnerable. Maybe out of compassion for Jane, she would see the light. But I didn't want to offend her, so I stayed politically correct, and I stayed quiet. I feel that we have all stayed quiet and politically correct far too long. People don't seem to believe in vaccinations or science. People, celebrities and fearmongers persuade them that the doctors and medical experts don't know what they're doing. Even government officials like the Spokane Valley City Council are taking a stand against standard practices that prevent the spread of disease. I've included a copy of their proposed ordinance and a letter from the ACLU. 1 minute, okay. I feel like this is a slippery slope. At what point is there a health concern for everyone? When 20% of the population isn't vaccinated? When 50% of the population isn't vaccinated? Understandably, it's scary. We all want to protect our children, but aren't we also called upon to protect the Janes of the world too? And the Barbs and the other people who are autoimmune systems are depressed? And what about their lives matter as well and deserve protecting? So I ask you as medical professionals to please speak the truth, even when it's uncomfortable and not politically correct. We need you to exert your leadership in this arena and devise policies and procedures that are best for public health for everyone. All the little Janes in the country are counting on you. Thanks.
Thank you very much. Thank you very much. Next we have Marianne Karchner.
Yep, you got it.
Thank you.
Marianne Karchner, Green Acres, Washington. I am a lifelong resident of Spokane County, and I have 4 children attending the school districts in Central Valley. I'm also a master's prepared registered nurse and an advanced registered nurse practitioner, an extensive experience in pediatrics, including immunology and vaccination. I guess I find it somewhat disturbing. I didn't realize that there was public comment in public health. So I guess I was a little bit concerned when I found out there were a lot of people against vaccination testifying to the community health district, to the public health district. And I guess I would just like to implore those on this board to realize that most of us out there support science and support vaccination, and we just didn't know that we needed to show up here and defend it, and that some people are coming in droves to fight against it. And I'm concerned just that you would stay focused on the science and know that we're out there and we will support you in that decision, and we appreciate the work you're doing keeping us safe. Public health is a very serious issue, and very difficult decisions are being made in these types of outbreaks. Nobody wants to hurt a child. That's what we're doing here. We're protecting children. When we exclude children who aren't vaccinated, it's not just for that child that's being excluded that's not vaccinated. It's for all of the people in the community. That's how herd immunity works. And it's a pretty basic science. My master's degree focused on the MMR and autism. I understand. I've actually read the studies. I know the studies. I just wanted to, I empathize with the parents whose kids have been sent home, and I totally agree we need better policies. They need to be better supported. Thank you.
Thank you very much. Thank you very much. Next we have Stacy, and I'm going to slaughter this last name. I'm going to say Homedale.
Really close.
What'd I get?
It's Homedal.
Homedal.
I'm Stacy Homdahl. I live in Green Acres. I have 3 boys. 2 of them are through Central Valley High School and off to college, and I have one in high school at CV. And my oldest son has Crohn's disease, and because of that, I know a lot about herd immunity, and he has to take immune suppressants to control his disease. So previous to his diagnosis and previous to having Crohn's disease and taking immune suppressants, Quinn was a normal kid. He got a cold. He got over the cold in 3 to 7 days. He was pretty normal. He'd get sick once or twice a year. Now that he's on immune suppressants, he gets nearly everything that everybody else at the school gets. So he would get strep 3 or 4 times a year. We had to have his tonsils removed because they got so big and they stopped responding to infection. So there's nothing I can do about him getting lots of colds. There's nothing I can do other than giving him a flu vaccine and wiping everything down continuously and making him wash his hands as much as possible to protect him from some of the viruses that are floating around in our schools. But the vaccines are important for people like Quinn because he can't get live vaccines. So he can't get a chickenpox vaccine. He does have MMR, so he's okay, but anything that he has not gotten that's a live vaccine he cannot get, and the immune suppressants will knock down his immunity even to things he's been vaccinated against. So, and we don't know. We don't know if he's still got full immunity to MMR. We don't know if he has immunity to polio anymore. We won't know unless he actually gets it. So for Quinn, it's really important that we have herd immunity and that everybody is doing their part to try and prevent these diseases, because I have no other way to protect him. I think that's what the woman who was speaking at the beginning was talking about, that's a cancer survivor. They're in a similar situation where they can't protect themselves. They can't necessarily get a vaccine, or I don't know with cancer if the vaccines just don't work. But that is part of the issue. You're not just protecting your own child, you're helping to protect my child. And I can tell you that with a weakened immune system, he does get far sicker and far more often than he used to. So that's a thing. It's real. So thank you.
Thank you very much. Next we have Phyllis Hess.
My name is Phyllis Hess. I live in Spokane Valley, 14425. No, 1104 North Bowdish. I have 4 older children who were fully vaccinated by 1987. They were constantly having sore throats, sick, seeing the doctor all the time. As adults, 3 of the 4 have autoimmune diseases. My daughter at 43 has struggling with lupus. Before our 5th child was born, we studied much about vaccinations. That was before internet. We read books and books and books and chapters of books. And we chose not to vaccinate. We have 5 younger children, same parents, same lifestyle. I have a 19-year-old who's never seen a doctor. My kids are almost never sick. They're healthy. My husband went through cancer, went through chemotherapy, was home with 5 unvaccinated children. He wasn't. He's a survivor. He also at one time, as an adult, got chickenpox. Yeah, it was hard, but he survived. I'm here for parents' rights. I think parents have the right to decide what they do with their children, what clothes they wear, what school they go to, what medical procedures they have. The parents have that right. It is not something that the government should be controlling. Thank you.
Thank you very much. Next we have Kaylani, and I don't have a last name, so I'm going to ask Kaylani that if she does speak to please give her last name for the record.
Kaylani Bonner, Spokane Valley. I would like to sorry, Payton Cold. I would like to shortly mention some conflicts of interest that put the health and safety of our citizens at risk. Industries that can benefit from huge profits when government policy, directives, or laws favor them have no business having a seat at the decision-making table at the CDC and FDA. Unfortunately, this obstruction of a just process has been the norm for many decades. Large pharmaceutical and chemical companies have been directly involved in policymaking. This sickening nepotism has an impact on every Spokane resident as well, and the sick care or health care they receive. One of the more recent developments since 2010 that's disturbing to me has been the coercive measures put in place to ensure a high uptake of the flu shot. The Affordable Care Act contains small print that put financial threats on Medicare reimbursement, Medicaid or Medicare reimbursement for hospitals if they do not have vaccination rates close to 100% for both employees and Medicare patients. One must ask, considering the proven low efficacy of the flu shot, who is profiting from such pressures? The answer is no mystery. I have a friend in this city who is a nurse at a hospital, a local hospital. She has witnessed nurses and has directly been ordered herself to give the influenza vaccine to dying patients. It helps boost the numbers, but this certainly isn't about patient protection. Flu vaccinations are offered to acutely ill patients upon admission at the hospital, despite the risks this could pose to their delicate health. If they're coming in with signs of kidney failure, flu shot. If they're coming in with signs of the flu shot. Children who are ill are often given vaccines despite the fact that this goes against official policy because it increases the risk of side effects for vaccine administration for children. Locally, despite the fact that we have a dire shortage of foster parents for babies and toddlers, the flu shot, last I heard, was still required for licensing of children under age 2. Because of the mumps outbreak with the exclusion policy, healthy children were persecuted and kept out of school. Many of these children and families face long-lasting ill effects of this unjust treatment. Vaccine failure is no excuse to punish and discriminate against children who are not fully vaccinated. Just a reminder from the Declaration of Rights and the Washington Constitution that all political power is inherent in the people, and governments derive their just powers from the consent of the governed and are established to protect and maintain individual rights. Notice it doesn't say that the government is established for the good of the community or that the good of the community trumps individual rights. An attitude of majority rule is a foe of liberty. Minorities must be protected. Otherwise, all we have is totalitarian democracy. If we don't have freedom, what difference does it make if we get to elect more people to oppress us and deny our freedoms? It's about time we have leadership at the health department committed to reject policies that are driven by profit motives at big pharma. Thank you.
Thank you very much. Next we have Jennifer Burrows.
Jennifer Burrows, Spokane City. So today I wanted to take some time and address some of the statements that were made by Dr. Lutz that I saw in the news from last week. The first one is that those who are more susceptible, i.e. those who have not been vaccinated, are more at risk and therefore more at risk for transmitting if they contract the virus. This common statement is not entirely accurate. Only immunity offers protection, and not everyone who is vaccinated develops an immunity. It stands to reason that the vaccinated portion of the population that has not developed immunity is also more at risk for contracting and transmitting the virus. Per the CDC, the mumps portion of the MMR has an efficacy of 66 to 95% after the second dose. It is clearly not 100%, leaving a percentage of vaccinated susceptible as well. I believe it to be more accurate to say that those who do not have immunity are more at risk for transmitting. You also stated that a parent has the right and responsibility not only to his or her family, but to the community at large. When the implications of school exclusions have such extreme impacts on the students excluded, then I believe it to be irresponsible to cling to policies that are based entirely on probability, especially with regards to diseases that are fairly benign compared to other infectious illnesses that don't require exclusions. Back in May, when I addressed the Health Board, I cited MRSA statistics from the CDC. Mumps pales in comparison to the danger and treatment difficulty of MRSA, yet an active MRSA infection does not require an exclusion. You also stated that you're not punishing students, you're not punishing kids, you're really trying to protect them. I don't believe, Dr. Lutz, that you're trying to punish students, but I really question whether that's a protection. We have very precise means of measuring immunity through titer panels. If public health is of utmost importance, then in an era of medical precision, why are titer tests not being considered to have on file with student records so that in case of an outbreak, all of the susceptible students, the vaccinated included, who have not developed immunity, are protected? Why is it that as soon as a child receives the MMR vaccine during an outbreak, they are immediately allowed to return to school without the time for the vaccine to take effect, nor the assurance that it has? The exclusion affected K through 12, which was harmful enough. But what about college level when the exclusion becomes not only an educational setback, but a serious financial loss? As pointed out in one of the last meetings this summer, the responsibility of the health department does not simply concern infectious disease, but also includes mental, emotional, and social health. If the current health board will not waver from the school exclusions, then I ask that the exclusions be for anyone who is susceptible, regardless of vaccination status. since vaccination does not equate immunity, and that very precise measures be put into place so that students don't fall behind at whatever level they happen to be in their education. The current system we have in place is flawed. The rhetoric of the unvaccinated being the susceptible group that needs to be excluded because of a potential threat to the community needs to change so that we can have a discussion.
Thank you very much.
Okay. Thank you.
And finally, we have Chris Jackson.
Hello, everybody. My name is Chris Jackson, 1907 South Bannon, Spokane Valley, Washington. It was hard to not notice the fact that tribes had already started emerging, even in this room, and I think it's one of the things that actually plagues this discussion, for better or worse, because I think at our core we all want the same thing. Nobody wants children to feel excluded. Nobody wants children to die. Everybody wants everyone to be as safe as possible. And so one of the things I want to talk about is this issue of exemptions leading off. And on May 10th, 2011, Governor Christine Gregoire signed a certificate of exemption for parents and guardians to exempt their child from immunization with a signature from the healthcare profession. So to a certain extent, this has already been addressed. And if you have religious exemptions for any reason, you're already good to go. But one of the things that I want to segue to is that policy is always imperfect and science is hard. I just received my doctorate after defending it this week, and so I'm keenly aware of the fact that we're always basing these decisions on statistical outcomes and likelihood probabilities. Are vaccines 100% perfect? No, absolutely not. But as most people in the science field know, this is always an ongoing process by the peers to find the best possible solution for the community. That's why people take this job on and why people want to work as hard as they can tirelessly to make this place a better world. Mumps, yeah, it's probably likely that it wasn't 100% attributed to the vaccine. So yeah, even if you get vaccinated, you're not always safe. But we got to remember that as a process, science requires that we adapt when the disease adapts. And I don't think the take home from any of these speeches today should be that we should stop trying as scientists to come up with vaccines that are 100% effective. Because measles and whooping cough are on the rise because parents are stopping getting those vaccinations. And we know that from the MMR perspective, we're pretty good at solving those. So just because one of the elements isn't working doesn't mean we should stop altogether. We should continue as a community to do our best for everybody. Seems odd that only in America can we beat a disease and then kind of let it come back for fair play, I guess. The short answer to sort of bridge both of the groups is that can policy be better? Absolutely. Those policies were in place when people were getting vaccinated regularly and the disease wasn't there. So let's work together to fix those policies. Thank you very much.
Thank you. That concludes a citizen input for today. We'd like to thank all of you for coming out and presenting your views to the board. Appreciate it. And so now we're going to move on to item number 4 of the agenda, the chair report. Given the break that we've had, the chair only has 2 items to report. One is that we have a third county commissioner that will hopefully be joining the board shortly, that has recently been appointed, and that I have contacted Commissioner French, and I will continue to contact him that he needs to address the vacancy for the open citizen member for the that is outstanding on the board. And at that time, that's all the chair has to report. So move on to number 5, the agency report. Torney.
And we'll start with Linda Graham and legislative.
Hi, good afternoon. So despite the fact that we're still waiting for the legislature to act on a couple items from last session, it's time to start thinking about the next session and developing your legislative agenda. As a refresher, the process starts with my talking with partners across the state, Department of Health, WSALFO, Public Health Roundtable, and others, and looking at what may be coming up next year and things of priority for us. I then talk with the policy committee. We met back in August. And then in September, I bring forward an initial list of ideas for your consideration. You have some discussion, add things, take things off, ask for more details. Come back again in October for further discussion, and then a vote in December. In your packet, you will find the initial list of some ideas to consider for your legislative agenda. I also included a recap of what happened last session, those items that were on your legislative agenda where there was actually some action that happened. And with that, what I'd like to do is turn things over to Brian, who's chair of the policy committee, to start a discussion among members about items on the list and things to add or take off.
So last year we created 3 tiers. The tier 1 are issues that we actually wanted to pursue ourselves regardless of anyone else, and assigned Linda the lead of doing that, kind of as a agency lobbyist in a way, except she's internal. And then the second tier is issues that other stakeholders are advancing but that we're very interested in. And then the third tier are those issues that we're interested in but we're more monitoring. And I think you can see, since we're in the second year of a biennium, the bills that are still alive from the last one they're still alive, some of them. So Linda took some priorities that we had from before and just showed us where those bills are as examples of how it would play out in the field. But really, what we're hoping to get feedback today and ongoing until December is this 2-pager, which is the proposed tiers of issues. But they're just proposed to start with. There's no presumption of them other than they're based on what we did last year. And so we're really looking for feedback, and I think the best way to structure it is to look at the 2 issues on tier 1, which are mental health / substance abuse system reform, and secondly, oral health. And so my question really to you is, anyone, do you think those should be there? Should one of them not be there? Should there be something else be there? And that's the question that Linda wants answered, I think. So I open it up to members of the board.
I would ask at this time, is this something that we need to move on right now, or is this something that the board can take back and look over and provide input at the next meeting?
The intent at past meetings has been some initial discussion on whether things should stay on, come off, other ideas to put on, and then what are items that I need to go back and pull together some additional research for you on.
So we'll open it up and we can roundtable it, or if people have an interest in speaking out on these right now.
I guess what I'm looking for is if you have a strong negative reaction to any of those 2, or a strong positive reaction to something that's not on there. Otherwise, we'll just carry on tier 1.
Mr. Hafner.
Well, I would suggest this is the first time that some of us have seen this, and what you've come up with through the policy. Okay. I would suggest that we give ample time for us to go through it, and perhaps email back to you, Breen, some of the concerns and non-concerns, and so that you have the full impact from the board.
If that's what people want, that's fine too.
Any other input from members? General agreement with Mr. Hafner? Seem to be some have-nods. Mr. Munch?
Yeah, I'd agree with that, especially since we're missing quite a few of our members. It'd be nice to get input from more.
So, Linda, from the policy side of things, what would be the date range of input that you would be looking for? I mean, how soon? Next week, week after next, by a drop dead? Is there a drop dead date you have in mind?
Well, the absolute drop dead date is December.
Okay.
Your meeting in December. We come back again in October. The idea is to get some initial stuff, more stuff on the table. If you have any other ideas, things you're working on as a local jurisdiction that would belong on here, that way it's all on the table here. We can refine it in the next meeting and then come back in December.
So I would ask board members to take these back, and based on the guidance that Linda has just provided here, to come back, be prepared in October to come back and discuss the legislative agenda. Mike?
Just looking at our upcoming calendar, there's another policy board meeting October 11th, so maybe we can get it done before that, so that in policy we can talk about it.
I understand. So, Ann, can we get an email out to our absent comrades and let them know that if they have input, they need to funnel it to Linda or Breen by prior to the October 11th meeting?
I have an amendment to the thing. We had a few other issues that aren't on this one that are potential to add. So maybe if Linda can just redo this memo just a little bit and add those other issues on it as potential so people could look at that ahead of time as well.
Okay. And just to give everybody a brief heads up, those are things that either there was legislation that came out last session or certainly have been talked about. One includes a tax on vaping devices. Another is increasing the tax on hazardous substances. And then there was a proposal for a tax on sugary beverages. So those are potential items to add. Also an internal request has to do with the homeless management information system. So I'll bring forward some more information for you on that as well. And then finally, I just want to note that in working with partners, there's going to be a big push again next session around Tobacco 21, raising the minimum age to purchase tobacco products. The board passed a resolution last year. We'll be bringing forward a resolution again this year, very similar, but the resolution will also include encouraging other jurisdictions, such as your jurisdictions that you represent, in passing similar resolutions. So we'll be bringing you a draft in October.
Thank you. Any questions or comments on Linda's agenda?
Yeah.
Oh.
Just one last comment. As we look over this, it's very comprehensive. I can't imagine anything that you've missed, Linda and Green, in regards to that, so good job.
Kudos. So, just 20.
Good afternoon. I have a few things that I want to share with you that are ongoing or things that we are watching. The first of those is just from a federal level. Recognize that our Children Health Insurance Program, the CHIP program, expires this Saturday, as does McVie. And so there are funding concerns from a federal level for those programs going forward. I understand that from the state level there is not as much alarm, feeling that it's more a politically driven thing, that these programs will be supported and that we should see ongoing support for those programs.
I had a question.
Yes.
Didn't it get extended to December, all those, at similar program levels?
I'm sorry,
didn't the funding get extended until December at same program year?
Not for that. So that funding has not been extended. It expires this Saturday and needs special action.
Huh.
Mike?
How many people does that affect?
Well, it depends on what the timing of the funding roll down is. So because it ends Saturday doesn't mean that we suddenly don't have any dollars. You know, there are dollars rolling forward in the program. If it extends longer, then it's going to impact all children in this state who are supported by the CHIP program. I don't know that exact number, but it's large. And the McVie funding is the funding that we have for our nurse-family partnership and work that goes on in community and family services. My understanding is that it is likely to be passed soon, but at this moment has not been, at least as of this morning. We had a agency all-staff meeting up at the Lincoln Center on September 14th. And at that meeting, we have had Rick Kramer, who has done a good deal of work for us in this agency in the past from Organizational Resources Group out of Olympia. And he has worked on things that we got in terms of feedback from staff surveys, looking at needs to improve team building and conflict resolution skills. And so he did about an hour's keynote for us there, and we'll be following up on October 17th, 18th, and 19th with various groups so that we cover all folks in the agency on building skills that deal with both teamwork and conflict resolution. Those teams are currently in the process of establishing norms for how they work together, and he will further that work when he gets together with us. Also, I had told you historically that we had applied for a grant from the Kresge Foundation to address health equity. Pleased to say that we have been approved on that grant. So we have an effort over the next 14 months to look at how we as an agency improve awareness and reaction to health equity in this agency's work, and then how we take that forward into the community. So very indebted to the Kresge Foundation for funding that movement going forward. You've heard a lot over the last year or so about foundational public health services. Two specific things that are being worked on in that arena. With Burke Consulting, who has worked with the state for 3 or 4 years on foundational public health services, they're working to gain better understanding of the exact cost basis for what would be defined as the foundational set of services. To make that job more easily measured, there is a technical advisory group of about 20 folks across the state from local public health and the State Department of Health who have gone through the foundational definitions and refined it so that we can get more accurate cost estimates. That work will be done so that we will have information for the legislature as we go forward. That work probably will not apply for this next session, but for the following session, as we did receive some specifically allocated foundational dollars in the past legislative session. Just updates on our facility. As you perhaps saw coming into the building, the front 2 restrooms are being totally remodeled. They're near completion at this point. But that has been a little bit of a challenge for the public coming into the agency, having to go to a different floor to use restrooms, but those are about complete. If you take a peek at the back of the building, you'll see that we are in the process of installing our brand new chillers. That's the HVAC system that will keep us at the right temperature next summer. So thrilled that that is coming in on time and on budget at this point. And then thirdly, hopefully you'll take a chance, if you didn't come into the building from the front, to take a peek at the front. This last Saturday, Dr. Bob led a group of about 10 staff to redo all the landscaping out front, and it looks terrific to become much less maintenance intense, and it looks great. And very appreciative to the folks who did that and for Bob's leadership on that. Also, to let you know that the Great American Smokeout is coming, and there is a challenge this year that is being put forth, a Stop Smoking Challenge. So if you or anyone you know is a smoker, this effort this year is to try and get them to quit on the Great American Smokeout Day on November 16th, whether that's for a day or a week or a month or permanently. So this is to find people who would then take a challenge and challenge another person to join them in trying to quit using tobacco. We have materials that can be supportive for anyone who wishes to take the challenge. We have quit kits that will help people understand how to prepare to quit smoking. We also have materials in those quit kits that would be things such as a water bottle with gum or cinnamon or toothpicks and straws, things that can help alleviate the physical actions that you do when you smoke. So if you know of someone or you yourself are a smoker and are working to quit, if you will let us know, we will also help get advertising out. So through Kim Papich, she can spread that word. This information is on our website. And we have a handout called 5 Ways to Get Ready to Stop Smoking that we can share with you and for anybody that you would challenge. So hopefully this is one more way that we can help reduce the use of tobacco. Also coming up this weekend, sponsored by Spokane AIDS Network, is an AIDS walk that will be on Saturday, kicking off at noon. It will be about a mile's walk. Anybody who wants to come can. If you register for it and pay a donation to that, those dollars will go to support HIV/AIDS work that SAN and our agency are doing. Also, this Saturday at noon, being led by community-minded enterprises, is an effort called Hands Across the Bridge, or sometimes Hands Across the Falls. It is an effort to look at addiction recovery and they're looking to get people to lock hand in hand or arm in arm all the way across the Monroe Street Bridge. So they have gotten permission to do this from the mayor, and that will also go off at noon this Saturday. So encourage you to participate or come down and support those who do. So those are the things that I have to update you on. Any questions for me? Great. And we'll conclude with Dr. Bob.
Where is the, I can never find the right one. Oh, okay. Right there.
Dr. Leslie, again, Tony, we do not have a comptroller report today. No. Thank you.
Bob Lutz, Spokane. So good afternoon. Today's health officer report. A couple topics I'd like to mention. I think we can all say, if you remember last time I talked about how it was a normal summer and kind of maybe how these are typical things that the health district does during the summer. I actually want to contradict what I said before. It actually wasn't a normal summer from a couple standpoints, especially from the environmental standpoint. So as you all know, we were suffering from wildfire smoke for a somewhat long period of time. And for me, it was interesting to observe the process that takes place within the agency when confronted with, in this case, sort of a natural disaster. So earlier in the summer, what had happened was some of the people in FEFR, it's a great acronym, Public Health, Emergency Response, Preparedness and Response. I'm still getting all my acronyms down, I apologize. We started having meetings to discuss what we would do if a natural emergency such as wildfires occurred. So we had weekly discussions, weekly conversations, and then when it occurred, we sort of ramped that up. And so we started having regular meetings. We actually started a group that was, again, meeting to discuss, well, where's the point of contact? It's coming in through communications. It's coming in through just the information line. How do we address those issues which the community is concerned about, i.e. breathing this air? So we worked very closely to ensure that our communications was going out. We were working with the news media, working with a variety of other resources to ensure that the community knew what to do in this kind of situation. So for me, as sort of observing this and being a part of it, was interesting to sort of note how a variety of different disciplines across the agency came together to essentially address this public health natural emergency. And I would suggest to you that that's oftentimes how it occurs. It's very much of a systemic approach to the issues at hand. And I don't have mine. Did you turn it up? Well, I will.
Try it now.
Much better, right?
Yeah, much better.
Thank you. Thank you. Over the past couple of months, I've had a lot of community conversations. This has allowed me to really kind of try to get a sense, if you will, of what's going on out there. I think it's, at some level, maybe rarefied air for me as the health officer to not really be out there trying to engage the community, engage elected officials, healthcare entities, partners, medical students, and the public safety sector, of just a couple, to kind of get a sense from them, what are the issues? What are the concerns that we as an agency should be looking at, and maybe as a health officer, I should put special attention to? And one of the things that I've been consistently finding is that people really don't fully understand what public health is all about. I mean, we're here today talking about, obviously, a focus of conversation on vaccinations, but irrespective, there's so much other work that public health does. And so what I like to do when I talk with people is I use this definition, because I think from the Institute of Medicine, it really sort of speaks to the fact that it's a social need for us to work together, to work and provide healthy opportunities for individuals in our community. So again, it speaks to the need of us as individuals to work collectively.
But please excuse this interruption. May I ask you to put a pin in this for a moment? We're going to lose our quorum here. Brian needs to take off, and I'm wondering if we can ask Dr. Letts to take a pause for a moment and bring forth the consent agenda prior to losing our quorum. So do I see any objections to the board to pausing Dr. Letts and bringing forth the consent agenda? So at this time, we will consider item number 6, the consent agenda, consisting of the meeting minutes from July 27th, 2017, and the July and August vouchers for 2017. Do I have a motion on the consent agenda as presented?
You do.
Second.
Second.
Moved and seconded. Is there any discussion? Seeing no discussion, all in favor?
Aye.
Any opposed? Thank you very much. And at this time, let the record note that Councilmember Munch joined us prior to, or just at the very beginning of citizen input. So we do at this time have a quorum, albeit briefly.
And my apologies for having to leave early. Thanks.
And thank you very much for alerting us to the fact before we lost our quorum. I appreciate that, Brian. All right, so Dr. Letts, please continue.
You were saying just an I think you really
Okay. Then I'll go on. So in my conversations, again, a couple of issues have really sort of come to the foreground, and those are these topics. We've talked about some of them before. We haven't talked necessarily about mental health, but I would argue that, again, as we know, there's oftentimes a strong interaction between drug usage, abuse, violence, suicide, mental health. And what I've consistently, again, talking with people, one of the things that I oftentimes question them is how much of this is at some level a function of people in pain. You know, I think that people use substances, people use alcohol. They have mental health issues, but again, which came first? And this always reflects upon the need for us to be looking upstream. What's causing the individual to maybe have some of these adverse outcomes that we see, that I would see in the clinic when they come in for depression, anxiety, or because they're using substances. So again, these are topics that oftentimes have come to the foreground when I've been talking with people. And so I think, again, it sort of calls upon us at some level to say, hey, this is important to us. Are we okay with these issues in our community? Just a little update on community health. We, as you may know, we're in flu season. It was in the newspaper today. We've had 3 cases of hospitalized influenza documented so far. West Nile virus. Okay, you hear about this every year. In our community, it's endemic in animals. It's not always endemic/epidemic in humans. But we've had 4 documented cases of West Nile virus. 3 that exposure occurred in Spokane. 1 outside of Spokane, and there's currently a 5th case currently under investigation. So West Nile virus, it's a virus that, again, is usually transmitted by birds, so it's out there and about, but then mosquitoes are the ones that infect us. So again, be aware that it's out there. We've had preventive messages on how to protect individuals and also what to do around the home. A little bit about vaccines. Again, these are just some of the numbers. Again, so looking back, this is the pre-vaccine era. These are some of the numbers associated with these vaccine-preventable illnesses that occurred prior to the vaccines being available. Since the vaccines have been available, we know that smallpox has been eradicated. Polio, almost totally eradicated, now only present in 3 countries. Present in Afghanistan, Kurdistan, and Nigeria. Measles, okay, we almost eliminated measles in this country, but we continue to have outbreaks. Why? Because measles outbreaks are definitely occurring in unvaccinated populations. I just showed this statistic with respect to polio. I think many of you have heard before how polio for me is a very personal issue, with my mother having contracted polio. Since the polio vaccine was implemented, look at the difference in the number of cases, almost 60,000 per year, down to a very small number. So again, this is, again, an evidence of the successes of vaccines. These are some of the policies that, again, have been effective in working with vaccines. And we'll be hearing more about that in a couple minutes. But again, these are some of the
Dr. Lutz, if you go back one slide, I just want to see if I'm reading this wrong. Does that show that the drop happened before the polio, or it started to dip before the polio vaccine?
So the polio vaccine, again, in 1955, okay. But again, the awareness of polio, so there were some trials that were going on at that time, but the actual polio vaccine was first implemented in 1955, yeah.
Okay.
So again, policies around vaccines, these are the ones that exist. I would suggest to you also that maybe there's good reason to consider the healthcare technology in that. Right now, one of the problems is, and we'll hear about this in a couple of minutes, that adults can go from state to state, okay? And maybe you have your records on file, maybe you have your records documented, but again, right now, technology doesn't necessarily exist to have that information available between states. I just want to introduce an idea. It's called the Carnot, okay? And this is a measure of if you will, how infectious, how contagious a disease is. So this is the average number of individuals who, when exposed to a virus, will come down with the actual illness. And so you can see that for measles, it's very high, 12 to 18, average 15. For flu in 1919, we know the great pandemic of 1919, yet an Carnot of 2.5 on average. Diphtheria, 6 to 7. Mumps, 4 to 7. So that again implies that for every one individual who contracts the illness, up to 5 people on average will contract that infectious disease if they come into contact with it. Again, I think it's very interesting for us that, again, look at the flu, look at the Ebola. We heard a lot of news about Ebola, and yet how contagious is it? Okay, you have to be exposed to bodily fluids, versus many of these others are from airborne droplets. And I just put this at the end. You'll see this slide in the future. This is actually something that John Weisman, our current Secretary of Health, introduced to me a couple of years ago. We look at the social ecology model as a means by which we can look at behavior change and how we can affect change. Oftentimes we in clinical practice focus upon the individual, and we encourage them to be actively more physically active, eat right. I would argue to you that policy is really a very broad-based approach of how you can affect the greatest change for the majority of individuals. So you'll see this in the future during my presentations. The structure of today, you'll have a couple of reports that are going to be presented. I'd ask you at the end, you'll notice that under Part D, there's time for Board of Health input. As much as possible, I'd like to kind of refrain from questions, if possible, during those presentations, just so we can hopefully answer them. You may find some of the questions answered as we go through, and then the final portion, we can have more Q&A. Two final things unrelated to my presentation. I just want you to know that the Health District is putting out a news release on violence. It came out a couple of days ago. There's a violence report that's coming out. I think it's very telling. I think any of us who have either looked at the draft report, know what's inside the front and back covers, it's concerning. And so the fact that we are at some level raising awareness in our community, I think certainly my conversation suggests it's an area of great interest. And then finally, but not totally unrelated to vaccines, we have a vaccination clinic. We have free vaccination clinics coming up in the next couple weeks at Shaw, at Reardon Elementary, Farwell Elementary, and Rotary Club sponsored. Questions?
Questions for Dr. Lutz from the board? Thank you very much. Any other agency reports, Tony, at this time? No. So we are going to move into reports. We have 3 reports, and then Dr. Lutz has left a period at the end of the reports for feedback. What I would remind the members of the public that are left is these reports are intended for the board. Questions will come and be fielded by the board. Should you have questions of the presenters or the board members, we would ask that you would hold those questions till following the meeting. Also, just to remind folks in the general audience that following the reports, there will be an executive session, which means we will need to clear the room following the reports. So we will then reconvene following that executive session for our board member check-in and announcement of the next meeting, and then adjournment of the regular meeting. So we will ask folks to leave the room. There's nothing other than some labor negotiation issues, but we will reconvene, and then we would ask that citizens who have questions use that time following the meeting to approach board members or SRHD staff. So let's begin with the reports. First up, we have Alexandria is going to give us a report on immunization and disease response.
Great. Thank you. Hi, everyone. I'm Alexandra Hayes. I'm the Immunization Outreach Program Coordinator here at Spokane Regional Health District. I've been at this agency for 7 years, and I'm truly excited to be able to be here today and address the board for the first time and provide some information about what our program does. I'm going to be joined momentarily by my key partner, Becky Dowdy, who is the Health Services Director from Spokane Public Schools. Following myself, Susan Joberg will be joining to walk us through the 2016-2017 mumps outbreak after action report, and then Dr. Lutz will then be concluding by providing some updates regarding the mumps exclusion guidance. So before I start diving into the data and really showing you what the picture of Spokane looks like with our immunization rates, I want to show you a framework from how our program actually develops our immunization goals and the tools that we actually use to measure our performance. So first is the Healthy People Framework. The Healthy People Framework is actually developed by the Office of Disease Prevention and Health Promotion through the U.S. Department of Health and Human Services. This framework is a set of science-based standards that are released every 10 years aimed at improving the health of all Americans. Through this framework, this is how we actually get our immunization goals to not only try and achieve here locally, we are also trying to achieve these at a state and national level as well, so that we're all collectively trying to improve the same vaccine series rates among the same age groups. A key performance measurement set that I would like to point out is the Healthcare Effectiveness Data and Information Set, also known as HEDIS. This is a critical performance measurement set in the healthcare provider community especially that really helps us as a health department engage in dialogue with our providers around immunization performance, because the HEDIS measure so many different dimensions of patient care and services, with a huge emphasis on childhood and adolescent immunizations as well as adult flu and pneumococcal vaccinations. And lastly, the best tool that we have to measure our immunization rates, most often in real time, is known as the Immunization Information System. And Dr. Lutz alluded a little bit to this, and I will try my best to give as many details as possible with this. Every state has an immunization information system. This serves as an electronic registry that houses the immunization records for the residents that live in its state. Washington has had one since 1996. It was formerly known as Child Profile. So right now we have over 8 million records in this particular system for children and adults of all ages. The problem is that while we have 8 million records, many of them are incomplete. Unlike our neighbors in Oregon and Idaho, we do not require here in Washington state that vaccines administered in our state be reported to this system. So when healthcare providers are using this tool to be able to assess patient vaccination status, they may not have a full picture if their family doesn't have the records ready to give them. From our perspective, whenever we're trying to generate data, we don't have a complete picture, and we know that there are missing records from that. So we have two groups that we focus on whenever we're looking at immunization coverage rates. Our first group is our 19 to 35-month-old children. So for our 2 to 3-year-olds, we look at a 7 vaccine series rate, and there are, of course, the 7 vaccines with a various amount of doses. There are various combination vaccines that can be used, but ideally all of these will be obtained by the child between the ages of 2 months and 24 months of age. Right now, based on immunization information data, we only half of our 2 to 3-year-olds have completed this series at a time in their life for which they're most vulnerable to these diseases. Washington State as a whole, based on immunization information data, is almost a 60%. Both of these are well below the Healthy People 2020 coverage goal of 80%. We do know, for instance, that the DTaP, it gets better. It definitely gets better. Right now, the IIS says we're sitting at 60%. Based on our kindergarten students, whenever they enter into kindergarten, they are required to report this particular vaccine to that school because it is school required. Almost 90% of our kindergarten students are fully up to date on DTaP. So we at least know sometime between the ages of 2 and 5 that we're hitting a 90% coverage rate with DTaP in our community. Same thing for our 13 to 17-year-olds, which is our second group that we take a look at. And same thing as our 19 to 35-month-olds. We do also focus on a vaccine series, primarily ones that the diseases are affecting them in real time at the moment in their life or as they enter into early adulthood. Even here, the data that we see here far, far below the 80% that's reflected in the Healthy People 2020 coverage goal. We do have another gold standard tool called the National Immunization Survey that the CDC does conduct for all of the states in our wonderful nation, and they always seem to have rates that show that we are performing at a much higher rate than what the IIS tells us. So we do often like to use the sources as a proxy measure, and we like to share that data that yes, according to some of CDC's tools, we may be performing better in some areas. What we have at our fingertips at all time to show true performance is the immunization information system and the data contained within it. The next set of data that's extremely important regarding immunization rates is our school data. Whenever we're looking at our school data, schools in Washington State are required to submit the vaccination status reports of all of their children to Washington State Department of Health by November 1st of every year. Once this data is released in February, we take a look at it, and we're really looking at immunization completion rates, and we really focus on our kindergarten through 12th grade students, because this gives us a picture of what are the completion rates for those school-required vaccines among this group. And we want this to be a higher number, and so in the first school year, 2013-2014, we were about 81.1% here in Spokane, and then looking at 2016 to 2017, we have achieved an 88.4% immunization completion rate. So it's definitely heading in the right direction that we are aiming for. The next data point that's especially key when we're looking at school data is our out of compliance rates. Out of compliance means that a student is missing one or more vaccines from his or her student chart, or they don't have a valid medical or personal philosophical or religious membership exemption on file. So these out of compliance rates, they have been very, very high in the past. And starting in 2013, school year for both kindergarten and 6th grade students, as these are the only two groups that we look at, as we have now hit into our 2016-2017 school year, we have achieved a 78% decrease in the out of compliance rate among the kindergarten and 6th grade students. So we want this number to be as low as possible, and it has had tremendous impact here in Spokane, watching this rate go down while Washington State as a whole has stayed relatively stagnant. So a lot of the contributing factors for why we're seeing the rates go the way that schools are hoping for, one is the biggest emphasis on making sure that they're complying with state law around immunization documentation. We worked really, really closely with our partners, which of course I think everyone here can say your partners are the key to the success of your program. They certainly are core to ours here. We worked with our area school nurses to actually standardize the process for collecting immunization records, how you review those, what are best practices for actually following up, and reaching out to families to get the information you need to be compliant with state law. We've also partnered with the schools along with Washington State University's colleges of pharmacy, nursing, and Eastern Washington Medical Reserve Corps as well to host what we call mobile immunization clinics. These provide a no-cost, convenient option for families to walk in and obtain any needed vaccines that their child may need to stay in school. Not only that, we do provide any vaccines at that time that they may wish to seek to either improve or maintain their well-being as well. To date, since 2013, we've held over 50 mobile immunization clinics. We've served over 3,700 children and adults and have administered almost 6,700 vaccines between our partners to these families that have joined us. Another piece of the puzzle to try and address the issues that we've been having around access is there are no locations for unestablished students to just walk in and receive no-cost vaccine services in order to stay in school. So what we had done with the local school nurse group, with our program, and then an area federally qualified health center, is to develop a policy where essentially any child who may be facing exclusion due to lack of documentation or missing vaccines, that they can actually go to the FQHC and obtain those and be able to provide that documentation to school with absolutely no issues. And they do not have to become an established patient at that site. It is, of course, always an option. So they do at least get connected to a medical home, but it is not a requirement. Nonetheless, it does help us address the access piece. And along those lines, even more so, we have developed a public health liaison model through which school nurses can work directly with families and those students who may be hard to reach, especially some of those students in our HEART programs, our homeless kiddos, that the school nurses can really make sure to get those direct services that they need for vaccines to those families through this particular model. So far, we have 5 school districts participating in this model, District 81 being the one who pioneered it with us and helped us work out the kinks. And the mobile immunization clinics, we're operating in 10 out of the 14 school districts here in Spokane County. Last but not least, we want to make sure that we have a competent workforce that are immunizing our community, as well as those that join us at our immunization clinics and through the PHL model. And so therefore we have worked collectively with our partners to develop a comprehensive vaccinator skills training curriculum. At this point, we've trained over 350 healthcare professionals on how to administer pediatric vaccinations appropriately according to best practice and CDC guidelines. So now I would like to invite Becky Dowdy up with me here, only because District 81, being the second largest school district in the state of Washington, the strides that this school district has made in terms of disease outbreak preparedness and response have had tremendous impacts that continue to echo throughout our state. And we wanted to make sure to give a few moments to the school district to celebrate some of their successes and highlights.
Well, I just want to preface this by saying that I supervise the nursing staff, not anything to do with our curriculum provision, so I don't have answers to those questions today, okay? And I'm going to stick to my notes so that I stay on target. So in 2015, as you all know, it hit the news that we had upwards of 5,000 students who were in school with incomplete vaccination records. In partnership with the health department, we have reduced the out-of-compliance rate to approximately 1%. This includes students who receive services from SPS but do not attend in our buildings. At any point in time, we have less than 100 students in our buildings who are out of compliance. This is out of 33,000 students. And include kids who are newly enrolled, so that number kind of stays pretty stable. A large part of this success is our access to free vaccine from the health department. Not only do they provide large vaccine clinics, they support my nursing staff so that we can take vaccine into the buildings and give shots on site. And this has been a very valuable resource for our families who are very busy and who maybe lack access to resources. The best example of the strong partnership between SPS and the health department was the recent mumps outbreak. My staffing levels would have made it impossible for us to handle that on our own. The health department staff worked tirelessly 24/7 to contain the outbreak in our buildings. And I did witness them working with principals and administrators to create ways for the excluded students to participate in testing and state athletic events. They hosted multiple MMR clinics. Had we not had the support from the health department in recent years, we would have had thousands of kids, potentially, in our schools infected with the mumps this winter. So I cannot overstate the value of the partnership that Spokane Public Schools has enjoyed with the health department, and we look forward to future collaboration. Short and sweet.
Thanks, Becky.
Yep.
All right, shifting gears just a little bit. I appreciate the opportunity to talk to the board about the big picture of the community mumps outbreak response. Susan Joberg, I'm the manager for epidemiology and immunization outreach. And it is our precedent that when we have had the opportunity to respond to a large outbreak that we bring that report to this board. So a little bit of the background. 1,112 cases were reported during the outbreak to this agency, all of which need to be investigated. 333 were confirmed mumps cases. The outbreak lasted 176 days, and over 2,600 staff hours were logged during that time. It doesn't include volunteer hours. We, in this agency, use a structure called the Incident Command System. It's a well-known structure across our country of how to organize people and activities related to a successful response. It started in this country actually with the fire service, the military use it. In the last 10 years or so, healthcare partners in public health have been trained in how best to organize and efficiently respond to an incident that has lots of moving pieces. In our agency, there's cross-divisional support to make that system work. Our community family service public health nurses participated in our response, public health emergency preparedness and response staff, of course our epidemiologists and immunization outreach team, and our public information office have all key roles in helping this response be successful. But it doesn't only happen within our building, as has been stated by many of us who recognize the value of our partnerships. Our pharmacies were huge partners in this response, both in terms of their actual spaces, like Save On Drugs or Albertsons or anybody else, but they also were mobile in taking their services to vaccinate teachers and staff at school sites. We worked closely with the schools, and I couldn't put it any better than Becky just described it in terms of what that looked like and how closely we worked with schools. We had a mobile service. One of our partners, Spokane Mobile Clinic, was actually able to take on wheels literally to different businesses to be able to offer vaccination to those businesses who wanted it. And several business partners themselves invited that service in to protect their workforce. We worked really closely with churches, particularly churches whose predominant congregation were Marshallese. The messages in working with those churches were around prevention and protecting their community. Several of them opted to offer immunization clinics as well at the end of services and other times. But that was a really key avenue for us to be able to target the Marshallese population and get vaccination to them and good prevention messaging. We always work with our Washington State Department of Health. There are critical experts that we turn to. In this instance, they also provided quite a bit of support for case investigation. And then we have a great relationship with our news media, both television, print, and social media. Our public information officer, Kim Papich, has incredible relationships with media partners, and so they really were advocates in getting good information out about what was going on, if people chose to be vaccinated, where those opportunities existed. This whole entire process is grounded in a basic quality improvement framework. Recognizing that no matter how well we do a response, how well we plan, that there's always opportunity for improvement to better serve our community, our agency, and our programs. We use the feedback from our community both in terms of acknowledging and appreciating what went well as expressions of frustration for those individuals who were most impacted by whatever it has been that we were working on, and obviously mumps had serious impact for families. So the first thing we do is plan. Protocols and processes that have been established by the Centers for Disease Control and Prevention and our Washington State Department of Health all that are based on science and case studies, guide how we have developed our own internal communicable disease investigation and response program. And then we follow that plan. We followed the protocol and established processes guided by our interim health officer and in consultation with Washington State Department of Health. This was a response to an outbreak of unprecedented scope and size. And then we check, and that's what this whole entire after-action review process is all about. We've gained feedback from this board, from the public, from our school nurses and administrators, from businesses and community leaders, pharmacy partners, and health officers from around the state whose counties were also impacted by mumps outbreaks. We have a wealth of data that hasn't existed before, and so we're charged now with using that data, analyzing it well, and figuring out how that can drive improvement going forward. And there's where we are right now, is those improvements, and we're acting on those to incorporate into plans for future response. So some of the key areas of response, for improvement as a result of this response was health officer involvement. At the time the outbreak started, we'd been without a health officer for 11 months. We had a great interim health officer who was very collaborative with certainly staff within our agency and leadership and with our Washington State Department of Health, but he lived in Colville. Recognizing the importance of having a presence to address this board and community during an outbreak is critical. And thank you for solving that by hiring Dr. Lutz. Nobody felt that absence probably more than the EPI team on a daily basis. Utilization of our preparedness staff. This is our expertly trained public health emergency preparedness and response staff, and though we activated them earlier than we ever have in a response before, we need to do it sooner. As soon as we know we're dealing with an outbreak, we need to activate that team and have them help us organize so we can focus on what we need to as epidemiology and immunization outreach. Case investigation management. We didn't know what to do with the volume. We have routine tools in place that support disease investigation. During one of the worst weeks of case reports, 47 reports came in 1 week. So just managing that volume of cases and making sure that we are completely addressing every investigation as we should. We need to improve some of those support tools. That's already happened, that's already in place, and we're ready for the next time. Public and partner information sharing. We use a process called situational awareness reports. We started these about 2 weeks into the outbreak. Again, we needed to start as soon as the outbreak started so we could bring all of the partners along with where we were in the response process. Our public information officer, Kim Papich, and our most senior epidemiologist, Mark Springer, hosted a couple of these Facebook Live in conjunction with the news media that were extremely effective. The feedback from the people who participated in those was very positive, and they want more, so we will schedule more. Our healthcare providers, we're in very close contact with our healthcare community on a regular basis, and mumps was no different. One of the pieces of feedback that we got from our healthcare provider was just at the beginning of the outbreak is nobody had seen mumps, and so having very clear case definition guidelines in their hands as quickly as possible. School nurse information. We have a very close partnership with the school nurse leadership in Educational Services District 101 across the county. And those nurse leaders are excellent at knowing what to do in response, how to identify illness. The breadth of schools impacted and children impacted also impacted a wider group of nurses who weren't as well grounded potentially in the tools that are of use. So supporting the school district and doing more widespread training to those nurses would help smooth that process. And then the final one, clearly working with school exclusions. As I mentioned, it's our responsibility now that we have good data to work with to really examine that data. It's an iterative process, and we're as committed to it as anyone to make sure that our actions meet the needs of the community and meet what we're supposed to do in mitigating illness and widespread illness. So Dr. Lutz is going to talk about this piece in greater detail, but I wanted to really just thank this board for an honest process along this path. I think everybody learned different pieces of what response looks like. It was uncharted territory for everyone in terms of the magnitude of this type of outbreak. I want to thank my staff. The immunization staff and the EPI staff were tireless in their commitment to what needed to happen. And we brought as much levity as was appropriate on a daily basis. Vacations were truncated, and commitment was just there, and they did an incredible job. We do what Spokane does best, which is come together to create resilience and to protect this community. Thank you. Can you pointer?
So as Susan alluded to, we're obviously at the agency really dedicated to, looking closely, critically of what we've done and how we can do things better. I'd suggest to you that the state is likewise has doing the same thing. As was mentioned earlier by Mr. Jackson, science is by nature a dynamic process. We're always looking for change. We're always looking for how to understand things in a different framework. And certainly the nature of this outbreak is an opportunity to do just that. It was unprecedented in its scope, in its magnitude, and the lessons learned are many. Certainly we've heard much about the exclusion issue, and one of the take-homes was that, yes, disproportionately the percentage of individuals who were affected by mumps were immunized. Again, numerically we can understand that just by statistics. But that said, were exclusions that were on the books at that time relevant and appropriate for what we have learned from this experience? And as such, the Department of Health has critically looked at this and said, you know what, maybe we need to revise the exclusion practices somewhat. And what they've done is to, again, critically look at the data and say, you know what, we need to be more flexible. We need to provide more opportunities for health officers and for agencies who are addressing the situation in the moment to really look at those situations critically and contextually. So what they've done is that rather than the existing exclusion practices as previously noted, they've provided that flexibility. They've said it's important for you as a health officer, for you as a health district to critically look at the situation. And based upon what you are seeing on the ground at the time, consider exclusion as a possibility, but not as an absolute. So I think from that standpoint, the lessons learned are very encouraging. Again, I think it really demonstrates the fact that we are a learning organization. Science is an iterative process, as Susan mentioned, and I think we've learned a lot from this. Okay, again, yes, it impacted many, but I would also suggest to you that many more were positively prevented from coming down with an illness, which ultimately is the goal of the agency and the health officer to prevent communicable diseases from spreading. So with that, as I said, I'll just leave it open for questions from the board at this time for any of us.
So questions for the board. Who would like to start? Mr. Munch.
So how many vaccines were administered during the outbreak? Do we have any idea?
About 7,500 to adults.
And that was just from here, or that was area-wide?
That's, well, those partners.
Okay. And once the mass immunization started, did we see a rise in new cases or a decrease?
The predicted epi curve for this outbreak went exactly as we predicted during week 1. So each cycle, the number of cases continued to go down.
Okay.
Whether I can't offer you a cause and effect for.
Yeah, I was just wondering if there had been.
Who actually got illness.
Right. And then on the case report, I think you kind of talked about that, but since you had 1,100 cases reported, but only 303 were confirmed, would it help free up more time if there was a better reporting or a better way for them to report, or because the hospitals are the only ones with EPIs, right? So regular doctors aren't going to be able to tell if it's mumps until they contact you. Is that how that works?
Mark, I need to turn to you that because it's more complicated than that.
So with the 1,100 cases, those are all cases that, that there's a suspicion of, with mumps. And so there's some clinical symptoms that are compatible with mumps. Maybe there's an exposure, but there's a lot of other conditions that can cause similar symptoms. We had people who were diagnosed with strep with similar symptoms. There were ultimately excluded people who were diagnosed with other viral and bacterial illnesses. So we depended really on our healthcare providers to throw anything that potentially could be mumps at us, and then it's a process of doing an interview and looking at the labs and waiting for those labs to come in, and looking at associations with other cases to finally whittle that down to what was confirmed or probable.
Okay, thank you. And then I guess, Dr. Lutz, the last question would be, as far as the more flexibility goes, what does that mean to you? Because I know this last time we were told that the state health department had basically said we're letting regional handle how they respond to this outbreak, but that seems like that really hasn't changed then, right? They're still just letting the regions handle it, and what is your thought? Do you have any thoughts on exclusions for this year, and if you're thinking they're viable or non-viable at this point, or what's our plan?
Well, I think first and foremost, we certainly hope that we won't have the need for anything like that.
Right.
I mean, so I think it goes without saying that we certainly are not looking forward, nor do we want to see another an outbreak of any magnitude. I think that, yeah, to some degree, they are looking, they're again sort of deferring to the health officer in conjunction with his staff to sort of, again, make that determination. But I'd also suggest that previous guidelines were at some level more prescriptive than what they are right now. Mm-hmm. So I think, as Susan alluded to, the lessons learned suggest that it needs to be very contextualized. We'll be looking much more critically at cases in any situation. And again, I would also suggest that we're looking at mumps. There are different ways to approach different communicable diseases based upon just the degree of contagion associated with it. But if I was to use mumps as an example, I think our approach will be much more contextual, much more dependent upon the situation, identifying, again, is it possible that the child contracted the illness in school versus out of school? And then looking at that, changing our approach to the exclusion. Is exclusion still on the table? Yeah, no doubt. But will it be as restrictive and as adamant as it was in the past? I do not believe so.
Okay. Then I guess the last question I would have then is, what is the exclusion exemption type guideline? Because we have new vaccines, are relatively new, chickenpox, different things like that. If there's a vaccine for a disease and there's an outbreak, is that going to basically trigger an exclusion, or are you rating the veracity of the disease or virus or different things like that before that comes into play?
With DOH guidelines are right now, again, being looked at critically from the standpoint of exclusions and how you approach outbreaks. The conversation has been around, at some level, creating a matrix, rather than being, again, very prescriptive and saying that this disease begets this, this disease begets that. It's, again, going to give guidelines because, as I mentioned, the diseases are different. So there's no one-size-fits-all for every infectious disease. So I think, again, as we look, the DOH right now is actively looking at almost every vaccine-related communicable disease and saying, does the current guideline, does the current practice fit given the science that we know?
Great.
With mumps, obviously, given past science, given this experience, we're changing the recommendations. Okay, and again, I would suggest to you, based upon my conversations with colleagues as well as at the state, you're looking at a matrix that's going to be, again, much more contextualized than what we currently see right now.
Excellent, thank you.
Certainly.
Next, anyone? Josh, Mr. Kearns.
With the discussion of exclusion, and we've been hearing it for months about a mandatory exclusion or a voluntary exclusion. Could you define what a voluntary exclusion is?
I would suggest to you that's somewhat of an oxymoron.
Okay.
I mean, the powers and authorities that are granted to the health officer to prevent an outbreak give my colleagues the authority to declare an exclusion in situations where we deem of importance. It's not voluntary, it's mandatory.
Okay. So there is no such thing as a voluntary exclusion when we're dealing with outbreaks and exclusions from schools?
As I said, it's an oxymoron.
Okay. All right, and so then the mandatory exclusion then is if there is an outbreak, all vaccinated kids cannot go to school. Is that correct?
Mr. Michelle, do you want to weigh in on that, being the legal, or do you want me to?
I'm just trying to clear up a question because
Understood.
for months we keep getting the same questions, and so I want to clear it up for everybody who testifies, so get those questions off the table, really.
Yeah, I guess I can repeat myself again. Exclusions, when a health officer orders them to be in place, is a mandate. It's not a voluntary issue.
Okay. All right, and so because I know we've also heard people saying that puts it on the schools, and then the schools weigh in somehow. That's not the case either?
The schools, I mean, again, they're going to defer to the health officer, to the health professionals to make that determination.
Okay.
So putting the onus on the schools was really an undue burden. Mm-hmm. So again, they will defer to us.
Okay.
And that's our responsibility to protect.
Okay. Thank you.
Certainly.
Other questions? So I have a couple questions, Dr. Lutz. Could you possibly go back a couple slides? Yes? So right there, that's great. So on these key, no, back down. Sorry. So on these key areas for improvement, are you and the team going to come up with responses to these actions? Will you develop some sort of report that basically says, here was an issue, here's our improvement action, here's how we're going to execute?
Yes.
Excellent. And so,
Again, not to be glib, but as I've said before, it's again a very contextualized approach. I think Mark, and the team in crunching the numbers, maybe I'll just let him speak a little bit to what his numbers showed and sort of explain to you how we're at least going to approach potential outbreaks of mumps, potentially.
I guess I'm more...
Or are you happy with just letting me say that yes?
Yeah, because I see two things. I see the epidemiology of an outbreak, and then I see the response to that outbreak.
Yeah, well.
And so you have the epidemiology, and everybody's tracking the occurrence and everything, but then you have to have a response to what's actually going on. And so my question is that out of the iterative cycle for improvement, are we going to get some type of report as the board as to these are the steps that we're going, we identified these 6-7 issues here. What steps are we going to take? Like, I'm not just talking about school exclusions, but how are we going to get more widespread training for our school nurses? Situation report sooner, more Facebook. What does that really look like and mean and everything like that?
So we actually have an improvement plan matrix. This is taken from that, where there's a responsible person assigned and a time frame in which that improvement needs to happen, and identified partners with whom that work must happen. And so that's our process after every response, is to make sure that that remains in front of whoever the responsible party is to make it come to conclusion. So for instance, the school nurse training, we're already plugged into that school nurse leadership group, and so it'll be with that group and the support of Becky and others that will help us more widely do that kind of training.
So I guess maybe for the board, not to belabor the staff, but as we move forward, if we could see some sort of summary as to maybe a little bit of what the nuts and bolts responses to these actions are going to be, that would be a good thing for us to digest, to see that we are actually taking action both as a board and as a health district and really addressing this. My other more question is that I'm kind of curious as to how there sounds like there's connections between the district, the school, the schools, ESD 101, the general health community, things like that. I guess I'm unaware of how rigorous or formalized are those connections, and my preface for this, or my background for this, is I think of something like if you have an oil spill. You have an incident response team, an IRT, you have an incident leader, you have bridge calls every morning to discuss this, everything like that. You have a formalized group established of people that are responsible at school, at various organizations, things like that. Do we have that sort of thing in Spokane County for these types of outbreaks? Or is it simply something where somebody from the school district talks to somebody here at the health district and we all kind of collaborate? Or is there, from this, do we see the need for actually developing a more formalized and rigorous structure, at least of interaction as one of these things happens, where we can communicate and get information very quickly between the various partners?
I think that system already exists.
Okay, then that was something that I was unclear of. So that system is there.
Yeah, that slide with this hub and spoke, I mean, none of that happens without existing and ongoing routine involvement with those partners, so that when the emergent situation comes, it's truly a phone call or the activation of an agreement and everybody's on board.
Excellent. That was probably a dumb and long question, but
no, not at all.
That question for me, so thank you. Mr. Hafner.
The thought that came to my mind looking through all this and the presentations, which, by the way, were very good. But here again, if we're looking at the issues and the improvement action with the 7% discount, to 7% budget cuts that we will be perhaps looking at, and I could say, Josh, this is kind of for your information, as long as you're sitting here, is that how does that affect the programs and so forth that we're trying to do in the improvement action, knowing fully well it costs money to do this? And so in a sense, if we don't have the necessary resources, we can't really make our community safe from that standpoint relative to a health issue. So again, I know that we probably have some financial at this time that operates well with us, but is a 7% going to affect any of this? It's fine and dandy that we're talking about it and all the concerns, but if we don't have the financial assets in order to do something with it, it does no good at all.
Mr. Hafner, I would suggest that anytime we lose resources, it becomes challenging. But I give enormous credit to our executive leadership team who looks at prioritization and where we need to expend the dollars that we are able to get on an annual basis. The challenge that we face more specifically is reductions in general fund dollars that we can shift easily. Our budget will actually be larger next year than it was this year. But that flexibility will be a little bit tightened. We will survive and we will pull this work together well.
I was hoping you'd say to the commissioner that we can't survive, we need to.
Well, I would say, Mr. Hafner, the 7% cut that we're asking each of our departments is for our internal department, and the Spokane Regional Health District is not one of our internal departments. So, yes.
Other questions?
I'd just like to thank the staff for this report. We've heard testimony for several months now about dissatisfaction with the way things went with the last epidemic, and kudos to the health district for having the learning mentality, for looking at what you've done very honestly and listening to everybody's concerns and making changes. So thanks for closing that loop and reporting back to us.
Mr. Munch.
You've done an excellent job since you got on trying to reach out to everybody that I know of, and I imagine you're doing the same thing with the schools and the superintendents there. Have you talked with many of the schools and school boards on ways to improve interaction this way yet, or is that not an area you've broached?
No, I actually, I've had the chance in talking with Dr. Redinger at Spokane Public Schools. As you know, we were looking at an opportunity to actually meet with ESD and the superintendents and the school nurses. I know that I've obviously met with Becky already, and we've had some conversations, but those conversations with other superintendents are forthcoming.
Okay. Excellent. Thank you.
Any other questions? Seeing none, that concludes item number 7, our reports. And so at this time, the board is going to move to item number 8, an executive session pursuant to RCW 423144, labor negotiation guidance. Michelle, who needs to stay?
We have Tony and Sue and me.
Tony and Sue and me. Ann is the secretary, stays or does not stay? Excellent, okay. We will reconvene following conclusion of the executive session. The executive session's going to take...
Sue, how long you need?
We'll say 7 minutes.
Thank you, everyone.